So we will start off with the blood supply to the heart. Now, the blood supply to the heart begins from the aorta. The aorta is going to branch out into two and supply the right side of the heart and the left side of the heart. The right side is called the right coronary artery. That will supply the sinoatrial node, the atrioventricular node, the right atrium, the right ventricles, and it will also continue back towards the heart, back around the heart to supply the other ventricle also. So the left coronary artery, it's a short artery that divides immediately, almost immediately, to form the circumflex artery that supplies the left atrium and the left ventricle. And this is the most important one, the left anterior descending, that supplies the left ventricle, the right ventricle, and the anterior septum. Left anterior descending, left circumflex artery. This is the marginal artery, anterior marginal artery. What I need you to understand is, in cases of heart attack, the most commonly occluded artery is the left anterior descending. That means the supply to the left ventricle mostly is going to get affected. Again, in cases of heart attack, if they ask the question, what is the most likely artery to be occluded, it is the left anterior descending artery. Next, we have the, I want to give you a small, I want you to understand this part. Let's say there is a block in the supply to the sinoatrial node and the AV node. So these control the basic rhythm of the heart. They control the normal rhythm of the heart. As you remember from physiology, there's the P wave, Q, R, S. Sorry. P. Here the P wave, Q wave, R, S, and a T wave. P, Q, R, S, T wave. But if there is an occlusion, if there is some abnormality in the blood supply, the blood supply can change. The rhythm will change. You will get abnormal conditions. This is called an ST elevation. You can see the P wave, Q wave, R wave, and the S and T wave, they have elevated. This is called ST elevated myocardial infarction. We are going to learn about this. Next, I'm going to talk about the anatomy and histology of blood vessels. Now, this is basic histology, but I want you to understand this. So, there's three types of arteries. There's the large elastic arteries, they stretch. Then you have the medium muscular arteries, and you have the small arteries. Now, if you remember, I talked about a word called sclerosis. Sclerosis, that is hardening of the arteries. That is going to affect mainly the elastic membranes. The elastic fibers are what is going to get affected. Sclerosis is the hardening of the artery, the aorta. Think of it like this. The aorta must endure a lot of blood, so it needs to expand. So if it becomes hardened, if it undergoes sclerosis, then it cannot exactly stretch out. So that can lead to hypertension. Now, medium arteries or the muscular arteries are what we most often get occluded. These are what atherosclerosis builds upon. And small arteries are less than 2 millimeters small. So this is going to be, I will talk about the histology. First, the outermost layer, the tunica adventitia, that contains adventitious cells, including squamous epithelia, You get a basement membrane whenever there's epithelial cells, and it's the outer layer. You get a lot of fibers too. Tunica media, smooth muscle cells plus elastin. And the tunica intima is the innermost layer. There's going to be a layer of epithelial cells, actually connective tissues, epithelial cells, you get those there. And there's, just before the endocardial layer in the tunica intima, you have an internal elastic lamina. It goes just below the endocardial, the topmost layer. And this is the lumen. You need to understand the histology of blood vessels. Next, I'm going to talk about arteriosclerosis and atherosclerosis. Now, this is the first clinical topic we are going to talk about right now. What is arteriosclerosis? It involves small arteries or arterioles. Hardening of small arteries or arterioles. There's two types: hyaline arteriosclerosis or hyperplastic arteriosclerosis. Now, the main thing I need you to know is this mainly occurs in the kidneys. So this is very important because kidneys hardening, the arteries hardening in the kidneys can lead to chronic kidney failure. So first, you will see pink hyaline. Hyaline is pinkish in color in H&E staining. Actually, it has a ground glass appearance, hyaline. So thickening of the walls of the arterioles can be seen. You can see that the walls of the arterioles are becoming thick. They're becoming thick. The media is becoming thicker, and the lumen is becoming narrower. So this, you can see the lumen has become narrower because there is going to be a pink deposit all around this. What causes this? Hypertension and type 2 diabetic mellitus. And the reason they say this happen is because there's going to be proteins. There's going to be proteins which is going to leak into the endothelium. So the walls are going to narrow because there's going to be proteins leaked into the endothelium, which is going to cause smooth muscle cells to proliferate, to grow and release extracellular matrix, that is the fibers. This usually occurs in response to endothelial injury. You learn the Virchow's triad. First, proteins will leak into the endothelium, causing smooth muscle cells to release extracellular matrix. In this case, hyaline fibers, causing the narrowing of the lumen. And over time, it can lead to chronic kidney failure because the blood supply to the kidneys is occluded. Similar concept here. Hyperplastic arteriosclerosis. There is going to be onion skin concentric thickening of the walls of arterioles. So you know what onion skin looks like. There's going to be concentric thickening. And here's the lumen. You will see lines and lines of fibers around the wall. For now, that's all you need to know. Next, you have atherosclerosis. Atherosclerosis is the thickening of the intima. We're going to learn the way it happens. So there's a chance this question can be asked for essay questions. So I will teach you to understand it. Now first, what is an atheromatous plaque? This is the this diagram here. You can see that plaque. Over here you have the smooth muscle cells under the epithelial layer. So first, there's going to be endothelial injury. Similar to how a thrombus forms, there's going to be endothelial injury with macrophages accumulating. Now the problem here is there is going to be cholesterol accumulation. In this wound, in this injury, there is going to be cholesterol accumulation because of hypercholesterolemia. That means when your blood cholesterol level is high, there is going to be accumulation of cholesterol. So what do the macrophages do? They're going to eat the cholesterol. They're going to ingest the cholesterol. And you can see these cells here. These are called foam cells. That is, they have ingested the cholesterol and are now called foam cells. They're full of cholesterol. This is why people with high cholesterol usually tend to get these atheromatous plaque deposits. That is going to narrow the blood vessel. Then calcium salts will also come and precipitate with the cholesterol salts. You can see those here, and they will form crystals. And then this structure, there's going to be a structure. If this is the blood vessel, you will see a structure. It has a shoulder on both sides. Like this. This is what you call a fatty plaque. Now what I want you to understand is, ever since you're born, you're going to start developing fatty plaques. Your body, if you are to take parts of the arteries, you will find that there are fatty plaques in your arteries. Remember, we are talking about arteries here. So these plaques, they will be present in almost everyone. Then it is going to harden into the atheromatous plaque. So what happens here is the smooth muscle cells. The smooth muscle cells, they will start dividing and proliferate. They will leave and come on top. They will come on top like this. And then they will secrete collagen. As you can see, they will secrete collagen. So what happens is, there is going to be a fibrous cap surrounding a necrotic center. So this can proliferate in two directions. This can grow in towards the lumen, or it can grow downwards, destroying the underlying tunica media. Now there is some advanced lesions, how it can progress even more. They can rupture, they can ulcerate, or they can erode. They can undergo thrombosis, or hemorrhage can occur, where there's going to be bleeding into this plaque. I will explain that. Or the part of it can detach and enter into blood as an emboli, atheroemboli. So I will explain this from the beginning again, but before that I will talk about the hemorrhage part. As you can see, there is going to be blood vessels on the shoulder of the plaque. On both sides you will see the shoulders. So that can bleed into this. So what happens then? is this will expand. This will expand and it can block the whole artery. This is the picture. You can see the necrotic core. There's going to be, you can see this hardened, it looks like crystals. That is cholesterol crystals formed with calcium salts. And this is the fibrous cap which has formed. And you can see the lumen has narrowed. It's supposed to fill this entire area, but now it has narrowed. So you need to know the areas where it is most commonly found. There's an mnemonic device you can use. The way I remember which is the most common is the abdominal aorta. That is going to get involved in cholesterol. Okay, no, that is wrong. But then it helps me remember, because the stomach, our gastrointestinal tract is in the abdomen. Cholesterol is absorbed from the abdomen. That's why I remember higher cholesterol is found in abdomen, abdominal aorta. But then that concept is wrong. It's just to remember. So you can use this mnemonic device to remember the abdominal aorta. You get it more commonly than the coronary arteries or the popliteal arteries, carotid arteries, and the least common area is the circle of Willis. A copycat named Willis. This clinical importance because over time, when there's occlusion, there's going to be chronic ischemia. Blood oxygen level is going to be low, and that can give rise to conditions like angina. It can eventually lead to, if the occlusion is greater than 75%, it can lead to a myocardial infarction, heart attack, stroke, etc. Next, you have acute ischemia. If the plaque ruptures and becomes an emboli, it can go and occlude the artery wall. That can lead to myocardial infarction. So next, you have aneurysms. The wall, now as you understand, there's going to be turbulent blood flow here because of this plaque build-up. There's going to be turbulent blood flow, and the smooth muscles, the wall is going to get weaker. Over time, it is going to expand. It is going to expand, becoming weaker, and that will cause the formation of an aneurysm, which can burst and which is very deadly. We have a condition called acute abdominal aorta aneurysm. That is in relation to this, or it can get occluded by a thrombus. That is occlusion by thrombus. This can cause blood to thrombose, and the whole thing can get occluded. Or it can cause critical stenosis. That's basically, it's going to narrow the lumen of the vessel, as you can see here. I will explain this again. First, you get endothelial injury, which is going to cause macrophage accumulation. Then cholesterol will come, and if there's an imbalance, if there's high cholesterol in blood, it will come into the center and start reacting with the macrophages, with calcium, and it is going to form a crystallized necrotic core with foam cells. This is what you call a fatty plaque. Now, what is important is this starts forming since we are children. You get these fatty plaques all around our blood vessels. That is something normal. But then it can form into a atheromatous plaque. That is, smooth muscle cells will proliferate, secrete collagen to form a fibrous cap. Now, this is a very hard structure. You cannot remove it. And it can occlude the artery or cause damage in several other ways. Two main ways I need you to understand is the hemorrhage and how an aneurysm occurs. Also the fact that it narrows the blood vessel and can get occluded by a thrombus. So when there's going to be blood stasis, blood slows down, platelets and everything will accumulate together and kind of trap the blood into a thrombus. You can call it a red thrombus here. Next, I will have done the basics of the cardiovascular pathology. We are going to learn about some clinical diseases, how clinically you get these patients. First, we are going to learn about ischemic heart diseases. Now, you don't need to know, I didn't write this note for this, for NMU pathology. This is my notes for USMLE. So, how does a patient present to the hospital? Usually, the patient presents with chest pain, which is radiating to the left arm. We need to understand how this happens. First, this pain is called angina. This pain is called angina. This occurs due to coronary artery narrowing, or this is important, or spasms. What is a spasm? The muscle suddenly constricts. The muscle, the smooth muscles in the blood vessel will suddenly constrict. Now that is called vasospasm, the blood vessel spasms. That type of angina, another name is Prinzmetal angina, vasospastic angina. The risk factor is smoking. You get this in people with history of smoking. Hypertension and hypercholesterolemia is not. Next, I will go in order. Stable angina. This is secondary to atherosclerosis, what I explained above. So what happens here is there is going to be more than 70% occlusion. 70-75% occlusion. This is called stable angina because you get the chest pain on exertion. That means when you're running up a flight of stairs, when you're doing some sort of exercises, you get sudden chest pain. This is not just a normal chest pain which you can easily bear. It's really painful. So this is due to reversible injury of myocytes, and as you remember, the hallmark of reversible injury is cellular swelling. Usually, if the pain does not persist longer than 20 minutes, then we can consider this to be stable angina. Now, this is important. In women, you might not get the chest pain, but out of the blue, they start sweating. They start sweating uncontrollably. This is a very common symptom in women, also in patients with stable angina. Sometimes in women, you do not get the chest pain. Instead, you might get sweating. Out of nowhere, you start sweating and shortness of breath. This resolves with rest or sublingual. Sublingual nitroglycerin. You place the nitroglycerin under the tongue because there's going to be a lot of blood vessels to absorb the nitroglycerin. Nitroglycerin is a vasodilator. It dilates the blood vessels. Next, I talked about vasospastic. Vasospastic or Prinzmetal angina, it is not caused by hypertension, high blood pressure, or high cholesterol. Smoking is the risk factor. So let's say you're doing cocaine or alcohol or you're smoking, and suddenly you get this chest pain. You don't have hypertension, but you're a chronic smoker, long-term smoker, or you're doing drugs, and you get this sudden chest pain. And how do you treat it? It's usually with calcium channel blockers, nitrates, and smoking cessation. The third type is unstable angina. Now, what I need you to understand is this happens even at rest. The difference between this and stable angina is this is going to happen even at rest. It's reversible injury, but it can very easily go into a myocardial infarction. So especially these patients, you need to quickly go to the hospital. Now I will talk about how you manage a patient who comes to the hospital. So when a patient with chest pain comes, the first thing, literally the very first thing you do is you get an ECG. So the patient comes telling he has chest pain, he has difficulty breathing, or you see he's sweating. The first thing you do is you do an ECG. Usually, if there is going to be stable angina or unstable angina, there is going to be ST depression. ST will be depressed. Next, you do a serum cardiac biomarker test. Now you need to understand, we need to know if there is a myocardial infarction happening. Our best tool is the ECG. If right now I'm talking about angina, you might see nothing, you might see no changes, no abnormalities, or you might see ST depression or even ST elevation. Next, to confirm if this is a myocardial infarction, is you do a serum cardiac biomarker test. Now what is this? These are substances that are released after, this is important, after a myocardial infarction. This is going to be after a myocardial infarction, there is going to be parts of the muscle. Now this is dead tissue that is going to release its substances into the blood. For example, there's a substance called troponin I or CKMB. Now troponin I is the one we check for, because CKMB can also be found in normal myocytes, normal muscles. Sorry, you will get them in normal muscles, skeletal muscles also. So serum cardiac biomarker test is done to see if there is an myocardial infarction which has happened. Don't get me wrong, not all myocardial infarctions are deadly. There can be small ones which can kill off part of the tissue. It all depends on the location and the size of the attack. Now, these cases I will explain later. Actually, I will do this now. So, a 70-year-old man comes to the ER with central chest pain, getting worse in the past 3 days. He reports he's not in pain currently and has a history of squeezing type pain. It's like someone is squeezing his chest for the past 5 years, that occur occasionally with physical exertion and resolves with rest. What is this type of chest pain? It's called stable angina. Why? There is occlusion of the artery. This pain has been occurring at rest for the past 3 days and is occurring more frequently, up to 6 times per day, and lasts a few minutes longer than usual. That means this has grown to become even more occluded, over 70% or 75%, it doesn't matter. His medical history is significant for hypertension and hypercholesterolemia. He's a smoker and a family history of heart disease. Now, these are all risk factors for hypertension and ischemic heart diseases. Vital signs show normal body temperature, blood pressure slightly elevated. As you know, the normal blood pressure is 120 upon 80. Pulse rate okay, but it's a bit high. Respiratory rate normal, oxygen saturation normal. His ECG shows signs of ST depression, which is consistent with acute coronary syndrome. That is some disease of the coronary system, the blood supply. And in this case, the answer is it's stable angina. So I need you to understand. I'm going to take these two. These two means there's incomplete occlusion of blood vessels. However, if this is going to get completely occluded, it is going to lead to a myocardial infarction. Complete occlusion. So, myocardial infarction on ECG are of two types. ST elevated myocardial infarction. The other one is non-ST elevated myocardial infarction. It's called STEMI or non-STEMI, NSTEMI. Now, if it is a STEMI, you will see the ST segment has elevated. You first do an ECG. This is the most important thing. On the ECG, you will see the ST segment is elevated. This is highly indicative of it being a ST elevated myocardial infarction. Next, you do a serum biomarker test. So what is important in this? The moment you see the ST elevation here, you don't wait around, you start treatment for myocardial infarction. That is, you basically give substances such as streptokinase, that you don't need to know now, but you start treatment for myocardial infarction. Next, you get the non-STEMI. This is more difficult to diagnose because ECG changes are either there's no changes, none, or ST depression can be seen. So you cannot, I repeat, you cannot depend on ECG for non-STEMI. You have to do it, but if the ECG changes are normal, if there's no ECG changes, now we cannot uh, just how do you say, assume the patient is not having a heart attack. You need to do a serum biomarker test. So if you see that the troponin I or the CKMB levels have increased, that means the patient has undergone a myocardial infarction. This is important. So why do we get ST elevation and ST depression? The main reason is the location of where the occlusion is. I will come to that to explain why you get ST elevation and ST depression. But before that, the second case study, severe chest pain. He says it began almost an hour ago while climbing stairs and has persisted despite rest. So this means he's undergoing, he had been exerting himself but not relieved on rest. That means most likely he is undergoing a heart attack. Tightness in the center of chest, short of breath, nauseated, sweating since the pain began. He reports a similar pain brought on by exertion, but it usually resolves with rest. Has a history of diabetes, type 2 hypertension, 30-pack year smoking. And this is important. There's a familial history of heart attack. That means if your parents have hypertension, or they die of a heart attack, or your grandparents or anyone in your family, you are at risk. Metformin, this is for diabetes. This is what you call a monotherapy drug for hypertension. That means a single drug you give. It's the drug type. The most commonly used drug is hydrochlorothiazide for hypertension. It's a diuretic. It increases the urine output of the body. Why is that important? When you have a lot of salt in your body, there's going to be water. I told you wherever sodium goes, water goes. So if we have a lot of volume of water inside the body, there's going to be, that water will be present inside the blood vessels. So that is going to cause hypertension. That is going to cause an increase in blood pressure. What you do is you give a diuretic to remove the blood volume to decrease, and a multivitamin. Vital sign shows a temperature of 37, blood pressure increased, pulse rate 100 per minute. He's in a very high, the pulse rate has increased to a lot. Respiratory rate is normal, oxygen saturation normal. ST elevation, which is diagnosed an acute anterior wall myocardial infarction. I actually gave the diagnosis. We had to we had to find the diagnosis, but what are the changes that can be seen in heart tissue during a day, a week and a month? I will explain all that here. I just wanted to go through the case. Next, I'm going to talk about hypertension. So what is hypertension? Hypertension is persistent or sustained increase in blood pressure. How do you usually diagnose this? You go to the doctor today. You get your blood pressure checked. It's high. It's above 120 upon 80. It's high. It's greater than this number. You go the second day, you check your blood pressure, it's still high. And you go a third day, and your blood pressure is still greater than 120/80. That's when you say you have hypertension, and also you need to start therapy. You start with monotherapy. That is a single drug, such as hydrochlorothiazide. Or an ACE inhibitor. It depends. It depends on the patient. Like you give ACE inhibitor when there's also heart failure happening in this patient. If there's a risk of heart failure, you usually give ACE inhibitor. You give a single drug. Later, if the monotherapy is not enough, that means there's going to be more occlusion of vessels, more causes for renal diseases, where less volume of urine is produced, so the water is going to remain in blood. Or salt retention, again, there's going to be water which is going to be with the salt. You give a combination therapy. That is a combination of 2 drugs. Don't worry, this is pharmacology. You don't need to know these. Yeah. I need you to know this. Black people are at a higher risk than other people for hypertension. Black man, no significant medical history, comes for a follow-up examination 4 weeks after he was noted to have a blood pressure of 150/80. This is the second visit. No complaints, no medication, does not smoke or use alcohol or any other drug. Often enjoys eating burgers with fries, and his body mass index is 27. So what does that mean? He's in the obese range. 25 is the cutoff point. Family history for a father with high blood pressure, and a maternal, that part does not matter actually, who died of breast cancer. His blood pressure on his visit is 150/90. On the second visit, it's high. What is the most likely diagnosis? The most likely diagnosis is essential hypertension of benign type. Essential hypertension of benign type. I will explain this. And what risk factors does this patient have that increases the risk for the above diagnosis? That's for you to do. Most appropriate treatment for this patient: 1, lifestyle changes plus a monotherapy. For black people, the most commonly used monotherapy is a calcium channel blocker. It's just that's USMLE stuff. You won't get that for anything in NMU. So what is the most likely diagnosis? Now, if the blood pressure is greater than 130/80, that is called hypertension. Hypertension is of 2 types mainly. Essential hypertension or benign hypertension is what most people have. Usually this happens with age, and if no complications occur, they will have a long life. It could be a secondary cause because of some renal disease. Kidney is unable to excrete salt, so water will retain in the body. That causes hypertension. Or Cushing's syndrome, where there is going to be adrenaline released. That is going to cause vasoconstriction of blood vessels, causing blood pressure to increase. Malignant hypertension, it's sudden. You get sudden increase in blood pressure over 180. Now this is how I know that this is benign hypertension, not malignant. 180 upon 120. Sudden. It's you go to the hospital with actual symptoms, such as you feel heart palpitations, or you go to the doctor and you feel, and you check the blood pressure and it is over 180 by 120. Usually in younger people, they die within 1 to 2 years if untreated. If you don't find the underlying problem and treat it, then they will die within 1 to 2 years. The reasons for this is hyperplastic atherosclerosis, again related to kidney, and necrotizing arteriolitis. It's a type of fibrinoid necrosis that affects the kidney. There's nothing much to explain in this, but basically what you need to know about malignant hypertension is it affects younger people. There's accelerated hypertension. So very quickly the blood pressure has gone up to 180 by 120, more than that, 200, 210, and so on. You need to find the underlying cause. Maybe there's some renal problem where the kidneys are failing. So all that blood volume is going to, the volume that has to be excreted is still in blood. Next, long-term hypertension, chronic hypertension. There's 3 phases. It's basically the same as benign hypertension, but basically we are going to try to understand what happens. So there's going to be 3 phases: phase of functional disorder, phase of atherosclerosis, and phase of organ disease. I will explain those here later on. Now, these are some factors which cause hypertension. You don't really need to know this, but I will just clarify the reasons for hypertension. It could be genetic or it could be environmental. There could be a defect in renal sodium homeostasis. If the excretion is low, salt and water retains in blood, the blood volume will increase. This causes the cardiac output to increase. The amount of blood pumped out of the heart is going to increase. In a minute is going to increase. Vasoconstriction changes. So you have hormones such as natriuretic hormone or adrenaline, which is going to cause vasoconstriction. Defects in the wall, where you get a thicker wall, or stenosis, a less compliant wall, that is, it cannot stretch as much. The total peripheral resistance will increase. These are physiology. So this will lead essentially to hypertension. Next.